All right, great. So you can see this. We have a small center here at the University of Maryland that's named the Center for Innovation and Diagnosis, and you can see the faculty who are on it at the right here and some of their interests. And um, this award is something that we started last year, and we plan to give annually. And it's for an individual who significantly changed the way we understand diagnosis in clinical medicine, and especially in a way that improves patient care. So last year, Gil Welch won this for the overdiagnosis of cancer. And a little bit about the center. We were started in 2021 with funding from an NIH New Innovator Award. And a lot of the early focus was around building this website, testingwisely.com, with a video game. And so there's things like these short videos to teach some of the basics of diagnosis, and a game that works on teaching some Bayesian updating as a clinical skill. And then in the past year, we've had a few things that have been the main focus for the center. There's a Society for Healthcare Epidemiology of America and CDC guidance that we worked on diagnostic stewardship or diagnostic excellence. So there was a series of papers with Shay about diagnostic stewardship. And then just a month or two ago, the CDC came out with the core elements of hospital diagnostic excellence programs that was a major effort for me. And we're hopeful will change the landscape of individual hospitals' efforts on diagnosis. So there's also been some work on AI that was really led by Katie Goodman that I worked on with her. She had some work around summaries and for generative AI and some of the issues that it can arise with those. This was a JAMA viewpoint. And earlier, she had a perspective in New England Journal of Medicine about preparing physicians for the algorithm era, which of course came out actually just around the time that GPT made a big splash. So it probably needs to be revised now. And then we had some work on related to the work we've done on clinicians being and how they have sometimes issues around thinking in terms of probability. We asked the same questions that we'd ask of a few hundred clinicians to GPT-4, and it seems like it actually performs about as well as clinicians in terms of estimating probability of diagnosis without any special training or guidance. All right, so I'm going to jump right into the main part of this, which is the awardee. So this is he is Ziad Obermeyer, and he's a physician investigator who I think has always been very interesting. He has excellent training and accolades. I'm not even 100% sure where he works, but he's affiliated with a few universities and spin-off companies, and has testified before Congress on AI. And I think I first really became aware of him back in 2017. I wrote an editorial on a paper he had on fever in BMJ with Phil Makoviak. And since then, I've paid attention closely what he's done. And I think what is most interesting about his work to me is that he is very good at using large data techniques and now AI techniques, and has been great at explaining these in a way that resonates with clinicians, which is often a big challenge. A paper that stood out for me that he worked on was published in the Quarterly Journal of Economics, and not really a hotbed of clinical medicine, but it was called Diagnosing Physician Error, a machine learning approach for low-value healthcare, where they looked at the diagnosis of heart attack, which is a pretty great model for diagnosis because it's frightening and bad when serious, but it's on a spectrum. There's a lot of mild or even just positive tests without disease. And it gets into how physicians estimate risk. And it turns out that physicians aren't that great at it. And it's still largely part of the art of medicine. And they found that it was easy to test more or less, and that physicians tended to test more often or less often, but it was very hard to test better. There weren't that many people who tested all of the people who were high risk and not many of the people who were low risk, which is the ultimate goal. And I think he's done a lot of interesting work around how machines can help us with that and how that could be integrated into to better healthcare. So I'm excited to hear this talk today, and thanks for coming to speak with us.
Oh, thanks so much for the invitation, Dan. This is so wonderful. And I think for me, it's a particular treat because I think my sense, and I'll get into why I'm optimistic about this later. My sense is that artificial intelligence, or whatever we're calling this set of techniques for handling large data sets that are very common in medicine, I think this is actually going to almost reboot medicine as a science, like not kind of genetics or the things that people do medical research on now, but like actual medicine as a science. And I think the group of people who do research on diagnosis are those are the closest people that I've found to the people who are interested in this clinical science that I think is really fascinating. And so I want to give you a couple examples of that today, and hopefully have enough time to chat with you all later, because I will be in Baltimore next week. Sorry, we're splitting the lecture virtually and the in-person stuff, but look forward to meeting some of you then as well. So so let me start by saying that I actually think when I finished residency in 2012. And I think it was around that time that some of these machine learning things were starting to get traction in other areas. Like there was the Netflix stuff, you were starting to see good traffic modeling and so I was just like really impressed by some of the cool things that AI was doing outside of medicine. And at the same time, I was a new attending in emergency medicine. I was at the Brigham at the time, and I was struggling with a lot of like just bad decisions that I was making that felt like the kinds of decisions that machine learning could really help with. And I think that the reason for that is that AI fundamentally takes a bunch of really messy data that we're going to just call X. This can be like everything you see about the patient in the electronic medical record, their chest X-ray, their EKG, whatever. And it uses all that data to predict one other variable, Y. And that Y, if you think about it as like, is this person having a heart attack? That can be really useful. Or can I send this person home because their risk of bad stuff happening over the next 3 days is low? So these are the kinds of clinical problems that I was thinking about a lot and struggling with and not doing a great job of. And I was like, wow, this is awesome. We can use AI to help us solve these clinical problems. And the thing that I think everyone in this field butts up against at some point or another is like, great, we want to use AI to predict heart attack. What is heart attack exactly? And so I'm going to give you two case studies. One is the paper that Dan mentioned, which if you talk about innovation in diagnosis, I think some parts of the innovation are scientific and other parts are figuring out which journals to publish in. And so my innovation in that area is publishing in economics journals, which I can talk more about later if anyone's interested. So that's the first one. It's like we fundamentally understand what heart attack is. We just don't always get it right when it comes to diagnosing it in individual patients. But there are a bunch of other problems that are at least as interesting as heart attack, where we don't even have a diagnosis yet. And I think AI can help there too. And so those are my two case studies for today. And I'm going to try to talk for about a half hour, which means I'll probably talk for about 45 minutes. But I'm going to try to go to leave enough time for questions at the end. So let's start with to borrow Donald Rumsfeld's taxonomy, the known unknowns, the things that like we know that there are heart attacks out there. We just don't know which patients to diagnose them in. And one of the consequence of that unknown part of heart attacks is that when we look at how physicians test for, sorry, I'm used to talking to non-clinical audiences, so I'm occasionally going to say heart attack, but I mean ACS. When we test for ACS and we look at how physicians are doing, we basically see that this is just like, one example of many examples of a broken healthcare system. Because when we look at the outcome of testing, and this is like stress testing, but even things like catheterization, we see that the vast majority of tests come back negative. And a negative test is, as anyone who's ordered one knows, you've exposed the patient to all of this cost and all this risk, and you're back to where you started. So it's great that you know that they don't have a heart attack, but it still means you got to figure out what they do have. Well, not necessarily in the emergency department. Sometimes you just send them out and tell them you don't have a heart attack, go see your primary care doctor. So on the one hand, we have this like waste, obvious waste, which is like so many tests that we order have all these costs, but no benefit really in terms of knowledge produced. And at the same time, missed MI is still among the top things that emergency doctors and primary care doctors get sued for. So we're seeing this kind of these two sides of overuse and underuse. And this is a great AI problem because if you had, and you could deliver to the physician, and the physician took it seriously, a precise, well-calibrated prediction on someone's risk of heart attack, you could reallocate some of those tests. So you could look at those high-risk patients who are above your cost-benefit threshold and say, look, this person should be tested. You confirm that they're having a heart attack, you figure out where the lesion is, you fix it, you have this huge treatment benefit that is pretty uncontroversial in the emergency setting for treating a new heart attack. This is very different from the stable coronary artery disease cath thing, which I think is a separate discussion. These low risk patients, we could just not test them and avoid exposing them to all the risks and the cost of testing. And so that reallocation is a fundamental downstream consequence of having good predictions. You test the high risk patients, as Dan, you said, and don't test the low risk patients, which makes sense in theory. It's just a lot of us have a hard time putting that into practice. So now I think comes the core methodological question, which is like, okay, great. We know what we want to do. We want to predict the likelihood of acute coronary syndrome. What is acute coronary syndrome? And like a lot of diagnoses, not all, but I'd say most diagnoses are an idea. What do I mean by that? Well, an acute coronary syndrome is a new blockage in the coronary arteries that results in a mismatch of supply of blood and demand of blood to the downstream heart. So we do not measure any of those things. We measure some proxies for those things. But fundamentally, acute coronary syndrome is an idea and a causal model that I have in my head that isn't directly measured. And I think that's the interesting and really annoying problem with a lot of diagnosis is that most diagnoses are models. Diabetes is insensitivity to insulin relative to so we have hemoglobin A1C, but that isn't diabetes in the same way that a lot of the tests we have for heart attack are not acute coronary syndrome. So how do we measure this idea? I'd say most of the time it's a cop-out because what we do is we try to get that idea out of the heads of humans that can look at some of the data, process it in ways that we don't frankly understand, and say, yes, this person had a heart attack or this. And this isn't a question of like cost or resource. This is like if you're at a pharma company and you're testing, $1 billion drug candidate, how do you define heart attack in your clinical trial? Well, you get the medical records of the patients in the trial, and you show the medical records to 5 cardiologists, and they vote, and that's called an adjudication panel. So we're voting on heart attack when we're not resource constrained. And this is a playbook that the artificial intelligence world has adopted wholesale because it looks a lot like their playbook of having people on mechanical Turk tag stop signs. So for them, radiologists and doctors are just basically high-paid M-Turkers that are labeling things. And so that's this famous Google paper, the first ML paper in a clinical journal on diabetic retinopathy. But basically, all of these studies, if they're well-resourced, they hire a bunch of doctors to label things. If they're not well-resourced, they just use ICD codes. But ultimately, we're just using human judgment as a proxy for measuring the ground truth, which we don't see. And the problem, a lot of the work that I've done outside of diagnosis is on how racial bias and other problems get into algorithm. And this is how. When you automate what humans think, you get a lot of great stuff. Humans are great. Many of my best friends are humans. But you also get all of the bad stuff about human judgment, the errors and the biases and all of the problems. And when we automate that, when we train machine learning and say, here is the truth, it's what the human says, you get all of the upside and the downside of that label. So what do we do in this paper? We try to have the machine learn from something that approximates the truth. And in our world, the truth is the result of the cardiac catheterization in the people who got cardiac catheterization. And so I know that there are some problems with this. Very happy to talk about those later, but we're going to be using the outcome of catheterization as a proxy for whether or not this person had an acute coronary syndrome. So basically, emergency patient comes in. First couple of days after that visit, we look at the catheterization results and we say, okay, those people are tested downstream from this emergency department visit. And we're going to take that sample of tested patients and say, okay, these patients, we can at least make some claim that we know the ground truth. Now, there's one very useful thing about knowing the ground truth in this way, which is, as you know from all these studies that look at wasted tests, it's very easy to see low value care. And that is predictably low risk patients whom doctors test, but then go on to have negative tests, exposing the patient to all of the costs and the risks, but none of the benefit of testing. So that's, I'd say, part one. And again, I'm going to gloss over a lot of the details in the interest of time. They're all in I forget how many pages this paper is. One of the nice things about publishing in econ journals is that the papers are 60 pages long. It's nice for the author. It's not so nice for the reader. But we take patients coming into the emergency department and we look at all of their prior electronic medical record data. That's the X, that's the input to the algorithm. And then we look at catheterizations over the next few days after that visit. And we say, predict the outcome of that catheterization. Is this a positive cath or a negative cath? That's what the algorithm does. It's a positive cath predictor. So then we go to a holdout set, tested patients that the algorithm has never seen. And we divide that set into 10 groups. So those are the 10 dots you see on this graph, lowest risk on the left, highest risk on the right. And on the y-axis, we're looking at the yield of testing. So the fraction of the catheterizations in each of these bins of risk that are positive. And what you can see is that it goes up, which is good. So the algorithm is assigning higher risk people to higher risk bins. And the lowest risk bins have a very low yield. So this is like about 1 to 2% yield. If you put that through the standard cost effectiveness calculations, you get a value of over $1 million per quality adjusted life year, which is very expensive. So even in the US, this is expensive, where the boundary is usually set at about $100,000 or $200,000 per life year. Conversely, if you look at that top bin, over half of those people have a positive cath. And so that is very high value care. Even in Europe, this would be considered high value care. The average, of course, is in between. So the average yield at this academic medical center affiliated with a very good medical school is 14%. So that, by the way, is still cost effective because there's a huge value to diagnosing heart attacks in the emergency department. But you can see how that algorithm lets us separate out these very predictably high risk people and very predictably low risk people, all of whom doctors today at this academic medical center are choosing to test and expose to catheterization. Okay, so that, predictable overtesting, not big news to anyone in this room. We all know that doctors overtest. And I think that it's not particularly surprising, but let me tell you maybe about the more surprising part next. So I'll start by observing that this training the algorithm and validating the algorithm in the people where we have approximations to the ground truth in the form of cath, that's great. But 98% of people don't get cath. And so what do you do with those people? How do you evaluate the algorithm on those people? This is a problem not just for us, but also for every single decision rule, the Hart score, the Grace score, the TIMI score. And everyone solves this problem slightly differently. But I think it's safe to say that in the clinical literature, nobody really factors in the huge difference between the people where we know the ground truth because they get tested and the people where we don't. So our approach is basically to say, okay, untested patient, we don't have the test, which means we don't have the test result. So instead, we need to go into a different mindset. This isn't the kind of like standard machine learning mindset where it's like, here is the label. I have predicted the label in a holdout set. It does well. Here is the AUC. We need to have more of like a detective work mindset. So we're going to look at those people whom doctors did not test. And we also take out people who are like over 80 years old, people who have competing illnesses that might make the doctors not test them, even if they suspect. So we do our best to take those patients that doctors might not test, even if they were high risk, out of the sample. And I'll come back to that later. And we look at those people who in the next 30 days go on to have a major adverse cardiac event that looks like it could have been undiagnosed and untreated heart attack. And so this graph basically shows you the same thing as the other graph, but with the untested patients. So we put the untested patients into 10 bins based on risk. low risk on the left, high risk on the right. And on the y-axis, we just calculate their major adverse cardiac event rate. And so that is, did you come back to this hospital and get diagnosed or treated with a heart attack? And diagnosed means you had to have a positive troponin in this case. So you had the diagnosis code and you had a troponin of over some high level. Did you have cardiac arrest or did you need to be resuscitated? Or did you die? And here we actually link to Social Security data. So we capture deaths outside of the hospital too. And what you see is that in that highest risk group, is the top few percent of patients, they have about a 16% adverse event rate at 30 days. If you look at the literature and you see, based on what the decision rules recommend, where the decision rules recommend testing, where emergency physicians feel comfortable sending people home, not testing them, it's about 1 to 2%. This is well above the threshold that emergency physicians at least have in their minds for, is this a high-risk group that I should have evaluated? It's not just, soft diagnoses or positive troponins. Like about a third of those adverse events are people dying. And so this is evidence that those high-risk people, according to the model, do go on to have events that could be undiagnosed and untreated heart attacks. So one of the problems, and again, this is not usually addressed in the literature, and this is where that mindset from the social sciences and economics really comes in handy, is that just because I've shown you they're high risk doesn't mean this was an error. Doctors see a lot of things that we don't in untested patients. So the algorithm only, to be useful, the algorithm has to deliver its predictions to the physician, which means the algorithm has to stop looking at some point so it can generate the prediction and give it to the doctor. We stop looking at triage. So we incorporate the chief complaint and the vital signs at triage. But then the idea is that's when you deliver the prediction to the doctor. What does that mean? It means that we don't see anything that happens after triage. And stuff that's important happens after triage. For example, people get EKGs and troponins done, and the doctor examines the patient. Maybe the patient has chest pain and is very high risk pre-test for acute coronary syndrome, but the doctor opens up their shirt and there's a huge bruise on their chest. It's like, yeah, okay, that's someone you might not need to test. So doctors see a lot of things that we don't. So what we're going to do next as a check on this is we're going to look at people who not only did doctors not test, but it looks like doctors didn't suspect either. And our measure of suspicion is, did they do an EKG? Did they do a troponin? These are the basic things that you'd imagine a doctor would do, even if they weren't going to cath the person, like just to know what's going on, to know if they can go home, to know if they need to go to the ICU. So in those untested and unsuspected patients, we still see a similarly high and unacceptable major adverse cardiac event risk. So in that subset of people where we are confident that the physician has not suspected ACS, they're going down some different diagnostic pathway, the algorithm is still able to find high-risk people that go on to have really bad outcomes in that month after their untested and unsuspected visit. Okay, so I'd say so far, if you were a nitpicky reviewer or a skeptical person in general, you might say, this is all great circumstantial evidence, but there's no direct evidence. So for more direct evidence, we're going to borrow another trick from the economics toolbox, which is the natural experiment. So what we do is we separate all patients into the triage teams. So this is like the nurses and occasionally the doctor during business hours that's working out in the triage desk. And we verify that basically on Monday afternoons, there are different teams working, but the patients look about the same. So if you come in Monday at 3 p.m. on one week, that group of patients looks a lot like the patients who come in Monday at 3 p.m. another week, but their doctors and nurses are different. And there's a lot of variation in your likelihood of getting tested, conditional on coming into the ED at 3 p.m. on a Monday based on who's working. It's about a 15–20% difference from like the top to the bottom quintile of testing. So it's a meaningful difference. So we're going to use that to do two things. The first is to run the standard playbook from health economics, which is to say, okay, sometimes you get tested more, sometimes you get tested less. Let's just see what happens. And when we compare those high versus low testing shifts, we see no difference. So this looks a lot like the standard story of like flat of the curve medicine, where on average, if you come in when you get tested more, you see a doctor who's more aggressive versus less aggressive. There's no difference. It's all the same. And the moral of that story is, of course, well, we should be testing less. But that is a statement about the average patient. So that's what that experiment does. It looks on average at different outcomes. The average patient is not having a heart attack. So now, through this lens of our machine learning tool, we can actually hone in on those patients, the top 1 to 2% of risk that really look like they are having a heart attack, and look at them through this tool of the natural experiment. Those people, when they come in on a high testing shift versus a low testing shift, they die about 30% less. So the average test is wasteful, but the average patient is not the patient we're interested in. We're interested in these very high risk patients. And for those patients, more testing has a lot of benefit, just as you'd expect. I should say that the next step we just got a NIH grant to launch this as a randomized trial in partnership with a large hospital system on the West Coast called Providence. And so basically here we're going to turn on the algorithm for some patients and not for other patients. And we're just going to see what happens in terms of both physician testing behavior, but also in terms of patient outcomes, because we're powered to detect some of these outcomes because they're so common in this high risk group. Okay. I'll editorialize a little bit on physician behavior here, which is that I think the dominant model, and I think sadly we have the economists to thank for this, is that, yeah, physicians overtest because incentives push them to test more. I think this is like the standard story that most people believe. Even, I think otherwise very thoughtful and smart people kind of accept the story without thinking too much about it. And that story, I'm biased as one of those doctors who tests a lot. This never made any sense to me. And the story that made a lot more sense to me is like medicine is just kind of a hard job and it's confusing. And a lot of the time we don't know what we're doing. And a lot of the time we just make mistakes because it's complicated. And so using this machine learning prediction, we can actually look at that directly. And so this graph shows you again, risk is on the x-axis, low to high risk, left to right. On the y-axis is the testing rate. So if you're in a particular risk quintile, how likely are you to get tested? And all I've done is I've separated out those triage shifts into 4 groups, the high testing shift versus the low testing shift. And what you can see is that there's good news and there's bad news. The good news is that if you look at that yellow line, the bottom line, in these low risk groups, it's much lower than the purple line. So in these low risk patients, the low testing doctors are testing them a lot less. Great. The bad news is they're also testing the high risk patients a lot less. And so they're basically throwing out the baby with the bathwater. Everyone's getting tested more or everyone's getting tested less, irrespective of risk. What you'd like to see is the slope goes up, or even better, there's just a threshold above which a robot doctor would test and below which the robot doctor would not. And we're not seeing that at all, not at the Brigham, and also not in all hospitals across the country. So we replicate these results. We don't have the EHR data. So this is just using claims, but we replicate this in all hospitals in the country in Medicare patients, and we see the exact same thing. High testing hospitals test everyone more, low testing hospitals test everyone less. So the picture that, at least for me, emerged is that we're used to hearing this stuff about, oh, there's too much testing. And then other people say, oh, no, there's too little testing because we still underdiagnose. But it's not about more or less. It's about figuring out who is the right person to test and testing those patients and not the other patients. So if you actually just let the AI allocate tests, the AI would cut about 2/3 of the tests that doctors currently do. So over testing that would reduce testing, but the AI would also add in about 16% of that total number in new tests that physicians are not currently doing. So the overall effect would be to dramatically cut testing, but those tests would also be substantially reallocated to high-risk patients that are not currently being tested and away from those low-risk patients that we are currently testing. And that's something that incentives alone just can't explain. There is no incentive model in the world that's going to predict that doctors are failing to test high-risk patients that are walking through the ER with high likelihood of heart attack, and they're going to send them home or diagnose them with pneumonia or do something else. Like that's not an incentive problem. These are, ACS is like a cash machine for the hospital. It's like catheterizations and ICU stays and consultation. Like you're not going to give that up under any rational incentive model. And so I think I'm not going to talk a lot about what we think is going on, but in the paper, if you have the appetite for reading a long paper, there are basically two behavioral errors that doctors are making. One is that doctors are very good at honing in on like the 10 variables that really matter for heart attack. And those are exactly the ones that you all know. It's age, chest pain, history of heart attack, all the risk factors. So we've done an amazing job of figuring out like the 10 things. The problem is that heart attack is more complicated than 10 things. And the advantage of the statistical model is that it can represent that complexity and look at thousands and thousands of variables and not just 10 variables. And so there's some evidence of that in the paper. There's also evidence of like a more standard just biases framework where doctors overweight risks from certain categories of variables, namely age, sex, and symptoms like chest pain. And they underweight the risk information that the model sees in these very complicated time series like vital signs and labs and how is your blood pressure today compared to how it's been over the past 3 years. And the model can see all of those things in a way that a human can't. Okay, so let me move on. Actually, let me stop there. And I think we're doing okay on time. So let me just pause and see if anyone has comments or questions about that first part before we move into the second part. David.
So a lot of interesting things come to mind. One is you're saying that if a test is negative, it's wasted. And I guess that's kind of a fundamental assumption that makes me say, well, isn't some sense of certainty that we've ruled something out? I mean, don't we still have must not miss diagnoses, or have we wiped that off the table? So that was one question. The other one is on your chart that's got the low risk, high risk, looking at the percent distribution of who's in low risk, high risk, it looks like there might be as many or more heart attacks living in the low risk population as are living in the high risk population. If you don't test the low risk, aren't we failing to test a certain number of heart attacks that are out there, even though the proportion of the population is low?
Yeah, two great questions. To the first one, there's always some simplifying assumptions you need to make progress. And so I don't want to fully defend it, but here's at least how I'm thinking about it, is that the way I would think about tests is that each test sits on like an accounting statement for its respective diagnosis. And so for the purposes of diagnosing acute coronary syndrome, a negative test, it rules out acute coronary syndrome, which is great, which is your point. But now you've just shifted the balance onto some other diagnoses that you now need to test for and figure out what they are. So I think you're right that in a model of like, well, my job is just to rule out the 5 bad things it could be, then, those 5 things, that's your budget. But I think I have a different view of diagnosis than maybe than most or a lot of emergency physicians, which is that your job is to actually figure out what is going on, not what isn't going on. And I think from that point of view, it is a waste when you have a negative test. To your second question, all of the bins, those risk bins are equally sized bins. And so you're right that there are still some heart attacks in the low risk bins, but because they're all equally sized, it's not an optical illusion that most of them are going to be in the high risk bins. But great questions. Feel free to just interrupt me if something occurs to you later, but I don't think I see any. Oh no, I don't have the list open. No more hands. Okay, just interrupt me if something comes up. So the heart attack example, I think, is an example of a setting where we basically understand what an acute coronary syndrome is. And we've made a lot of progress over the past 50, 60 years on how to measure that. We're just not that, because the measurement is not trivial, because you can't cath everyone. It's still a problem to figure out who needs to get the measurement or not. So that's kind of the type of diagnostic problem I put acute coronary syndrome in. We understand it, but our measure for it is something that needs to be allocated appropriately, and we're not doing that very well. think there's another kind of diagnostic problem that I'm increasingly finding at least as interesting as the first, which is where we know that bad stuff happens, but we have no idea why. And I think that there's a way for artificial intelligence to make an enormous amount of progress on this, but it requires a different playbook. It's quite different from the standard machine learning playbook of like just predict something. Even though, as you'll see, it starts from predict something. And so this is the case of sudden cardiac death. So I don't think it's an exaggeration. I don't think I'm being hyperbolic by calling sudden cardiac death a medical mystery. It's a lot of people who just drop dead. And I think the tragedy of sudden cardiac death is that some large fraction of those are preventable by implanting a defibrillator. We're just very bad at figuring out which people to implant those defibrillators in. So obviously those hundreds of thousands of people die without a defibrillator. So many false negatives. But there are also a bunch of false positives. There are about a third of the people in whom we implant a defibrillator. The defibrillator is now monitoring all of their arrhythmias. They never go on to have VF or VT or the things that they got the defibrillator for. So this again looks like one of these overuse and underuse at the same time problems. And it would be very useful from a resource allocation to predict who should get one of these things. The current state of the art of prediction for allocating this thing is measuring the ejection fraction of the heart via typically a cardiac ultrasound. And so I just want to outline the playbook by which ejection fraction became the standard, because we're going to run that playbook again for our method. So there was an observation in the 70s and 80s that people with low EF had high risk of arrhythmias and high risk of death and high risk of arrhythmic death. That got turned into a standardized imaging-based biomarker, the left ventricular ejection fraction. And then through a series of large randomized trials in the 1990s, a large mortality effect was demonstrated in those patients from putting in a defibrillator. And so that's the three elements of that playbook. So what we do is to basically run that exact same playbook. So working with a Swedish region where you can get all of the data from the national healthcare system, which is a luxury we don't have in this country, we get every single ECG that was done in that region. And we link those ECGs to death certificates where we see the cause of death, like where the death happened, everything. And as I said, this is really nice because you just get everyone, like all healthcare gets delivered through one system. Everything's linkable through a person ID number that's standard across the whole country. So this is a very nice data setting to work in. And then we just like predict. So we predict in the year after you get your electrocardiogram. Most of these ECGs are like outpatient, like primary care or cardiology ECGs. About 25% are done in inpatient settings. So we don't distinguish those, but we just look at the year after the ECG. What is your risk of having sudden cardiac death as measured by your death certificate? And you can see that the number goes up. It was good. And so we look at what's high risk for sudden cardiac death. There are no guidelines, but if you look at randomized trials and you look at the control group, so these are people who did not get a defibrillator, but they just followed along and they measured the risk of arrhythmic death. The median is about 5% per year. And in our high-risk group, we can identify a substantial number of people, it's about 2% of the sample, who have a higher rate than that. So the average rate for them is 6.1%. That's 1.8% of the sample. And by comparison, if you look at people with measured left ventricular ejection fraction who have a low EF, those people have about a 4.4 rate of sudden cardiac death. So it's about the same, maybe a little bit lower than our high-risk group. But very importantly, there is very little overlap between those two high-risk groups. So the people that we are finding in orange are new. They are not people who are known to have low left ventricular ejection fraction, and yet they have this very, very high risk of arrhythmic death in the year after their ECG. The overlap is under 10% if you look at the total pool of people that we now think, or at least we, the authors, think are high risk. There's a large graveyard of ECG-based predictors that predict arrhythmia or sudden cardiac death, but then when they get tested, they don't finding those people and putting defibrillators in them does not do anything. So as one just preliminary piece of evidence, what we do is we look at people who have our ECG-based marker of being in the high-risk group, and we look at the people who have ICDs, and we compare the high-risk people who have ICDs to the people who don't. And the ones who have ICDs in place die about 56% less than predicted. And this is about the same for sudden cardiac death and for all-cause mortality. And it's about the same magnitude as when we run the exact same analysis for people with low LVEF who do or don't have a defibrillator. Another question that often comes up about machine learning predictors is like, well, do they generalize? And so we actually take that predictor from Sweden and we apply it directly to a Taiwan hospital registry. So can't get much more different. It's a different ECG system, different country, different design, where they have people who come into the emergency department and experience sudden cardiac death in the emergency department. And then they follow those people along after doing all the medical record review and figure out who had an arrhythmic death and who didn't. And our model discriminates the primary cardiac arrests from controls, and it does not discriminate the non-cardiac arrests from controls. So not only does it generalize, it hones in on these presumed arrhythmic deaths in a way that is very helpful. We also take the model into a Southern California-based EHR cohort and find that the model predictions correlate really well to the incidence of ventricular fibrillation and ventricular tachycardia in that cohort. So in the US, of course, it's harder to link to death certificates, so we have to use these other measures. But those other measures are quite helpful, both, again, for generalizability and for mechanism. Getting access to these data is just a huge pain in the ass. Getting the original data from Sweden took me about 10 years. And I think this is a huge problem for people who want to develop AI algorithms and people who want to validate them and make sure that they're working well in different settings, that they're not racially biased, things like that. So I'll just mention two non-academic things that I've helped set up. One is called Nightingale Open Science. So this is a AWS-based platform that makes data like that Taiwan cardiac arrest registry data available to anyone free of charge. You can access it tomorrow if you want. You just sign the data use agreement and you'll get access immediately. Another is a for-profit company that I helped co-found called Dandelion. It aggregates data from large non-academic medical centers across the US and makes those data available to people who want to develop products that improve clinical care. Okay. So let me switch gears for the last 5 minutes and go back to that playbook for making discoveries. So if you look at something like Brugada syndrome or even the initial observations in the 1910s about heart attack, the discovery playbook starts with a correlation. So basically you see a funny squiggle in the ECG, you notice it because it happens in a patient with a terrible outcome. And then you slowly accumulate evidence that this correlation is robust, the correlation between that weird squiggle on the ECG and the outcome you're interested in. You can then look at the squiggle and based on your human understanding of how cardiac electrophysiology generates the squiggle and how pathophysiology distorts the squiggle, you can form some hypotheses about what's going on. And then you do the experiments that either confirm or refute your hypotheses about mechanism. So that's sort of how Brugada and WPW and like all of these things that we've discovered about the ECG, how they've happened over the past 100 years or so. In our setting, we've got a problem, which is that initial correlation between the ECG and the outcome, it's very robust. This is like more robust than anything a human could do off the bat. The problem is that there's no waveform. Like the model can take in a waveform and say, this is, P equals 0.83, but it can't tell us what it is. So we can run all these like standard interpretability things, but that can only tell us where it's looking, not what it's seeing. And that is a huge problem for this downstream process of discovery, because without that biological signal to reason with, we can't form hypotheses about the cause and we can't test hypotheses. So this is, again, sorry, this is at a very high level, but happy to get into the details afterwards. we train a new model, a generative model of ECG waveforms. So this is, like chat ECG. And we use the predictive model that can look at an ECG and tell us if it's high or low risk to basically coach the generative model into producing higher and higher risk ECGs. So we start with like your ECG, one patient's ECG, and we ask it to say, okay, tweak this ECG, follow that risk gradient up and up and up until you get a very high risk ECG. And what that lets us do is abstract from the insane complexity of the ECG. Like 2 patients, one died, one didn't. Their ECGs are going to be very different in lots of ways. This lets us just hone in on the things that the model thinks are important for risk. And so this, there's a lot to look at here. This is like a beat by beat representation, 12 leads of like the standard patient, like a random patient that we took in purple. And then the orange is the morphed version that the generative model has created that is a very high risk ECG. So if I were cruel, I'd randomly call on people and ask them to, but luckily it's not that kind of talk. And so I'm just going to hone in on one thing that caught my attention as a human, which is seen most clearly in L, but you can see it everywhere if you're looking. Basically, that sharp, symmetric S wave that you see in the low risk patient gets replaced by this weird little, like there's a slurred downstroke of that QRS in the high risk patients. And you can turn that qualitative insight into like quantitative features based on like the first and second differences, so the slope and the slope of the slope of this thing. And those new features are great. They predict the outcomes that we care about like quite well for a single feature in all the different cohorts. So there's this new feature, but what is this feature? So this is a very simple version of like, I think a thing that, we could do much better and we will do much better. But imagine instead of a heart, just imagine like a little rectangle of myocardium and imagine you've got an ECG lead that's pointing, in one direction. And in a normal world, you've just got a wave propagating from left to right. And your EKG lead is just going to pick up a positive deflection and then it's going to go away. Now imagine that you've got randomly distributed little obstacles to conduction throughout that little rectangle of myocardium. Basically, you're going to get scatter. So the wave is going to split around the first one, but then it's going to split and split around the second one. It's going to keep splitting. And what you might get is something that looks very much like a slurred downstroke where the slope decreases over time because the waveform front is getting more and more orthogonal to the ECG lead that's measuring the wavefront. So that's a hypothesis. And we haven't yet done a lot of experiments here, but here's one interesting fact. So we can look at in the high-risk patients in our sample, a handful of them have gotten cardiac MRIs. A downside of Sweden is that they don't spend a lot of money on things like cardiac MRIs. So we don't have as many as we'd like. But for the ones that we do have, there's a there's a much higher prevalence of very subtle late gadolinium enhancement throughout the left ventricle. And this is the kind of thing that it's very subtle. And with gadolinium enhancement, you can't even see it unless it's heterogeneous. So if you had like diffuse, like very diffuse, subtle late gadolinium enhancement, the radiologist usually doesn't even call it because there's no contrast. But if we look at the high-risk patients and compare them to the low-risk patients, there's a much higher prevalence of this subtle finding in the high-risk patients than the low-risk patient. And this is the kind of thing that the cardiologist doesn't mention. Like we can look at the note after the patient gets the cardiac MRI. No cardiologist ever mentions this or does anything about it because it's just like, eh. But it is the kind of thing that actually can, in the right setting, represent myocardial fibrosis. And why is that important? Well, because fibrosis is exactly the kind of thing that could give you a scatter phenomenon in your ECG wavefront. So, I mean, do I think this is true? No, like almost certainly not. I think it's worthy of testing. And I think more importantly, it illustrates that you can recreate this loop of empirical observation, but this time from a machine rather than a human, into hypothesis generation and hypothesis testing in a way that I think can be really productive for medicine. So let me stop by trying to sum up what I've learned, at least from these projects, which is that if you want to use AI for diagnosis, you have to think really carefully about what the diagnosis is and how you measure it. And sometimes we've got a good test and the AI can learn from that test, but there's a bunch of statistical problems that come up that are usually in the clinical literature unaccounted for on how that algorithm can generalize from the tested patients where it's learned to the untested patients where it hasn't. In other cases of diagnostic research, we've got an outcome we care about, like sudden cardiac death. And the AI is very useful in tying that outcome to some biological signals. But closing that loop requires human expertise. Why does it require humans? Well, because the model of fibrosis and scattering, like the AI doesn't have a model of the heart. We can try to tie it to computational models, but ultimately that process of reasoning and hypothesis generation today is something that can only be done by a human. And I think that's why I'm very optimistic that AI and these kinds of problems in general is going to provide the groundwork for rebooting medicine as a new science in and of its own right, in a way that we just couldn't imagine before. Because how could you handle an ECG in a regression before? Well, you'd need to show it to a human. The human would have to mark off some stuff that's in the ECG, and then we can put those things in a regression. So you just couldn't do statistics with images and waveforms before, but now we can. And images and waveforms turn out to be pretty important for medicine. It's a good part of the information that we consume and use on a day-to-day basis. So a science of medicine that doesn't account for these kinds of things just seems kind of silly. And so I think it's very exciting for me to think about, and I'd love to hear how you all are also thinking about these kinds of things, because I think this is going to be a fundamentally new kind of science in the next 10 and 20 years. All right, let me stop there and would love to chat.
All right, great. Well, thanks a lot for, I mean, it's a very interesting talk. I have lots of notes here, but I'll probably pass it over to the audience to ask questions first. And this is the time where I'd sort of like present you with some kind of like award or something, but we'll follow up in person next week with that. But it really did get me thinking about a lot of things, which as an ID doctor, I don't look at EKGs much anymore, but it made them interesting. And
Oh, I mean, I have to say that like I basically had to spend a month like learning the ECG again, because all of these things you're taught in medical school, they're more like rules of thumb.
yeah, that orange book, right? Where you like memorize.
Yeah. And I think that's a good example of how medicine today is fundamentally not a science. There's like a lot that's why memorization is so annoying and like, or that's why I found it so annoying, is because like you're just memorizing stuff. There's no underlying model, but there is. You just need different methods to get at those underlying models.
And I'll maybe throw out one question before jumping into the audience. How do you find physicians to be as far as accepting the idea of needing to use probability? I mean, it seems like all of these things kind of come back to probabilities and sort of scores and risk, which we do in medicine, but we often don't sort of operationalize it in terms of actually being quantitative or accepting that there are different probabilities that exist at the same time. Have you thought much about how to sort of try to translate that to the clinical world?
Yeah, I mean, I think my view, I have a sort of maybe like non-standard view on this, is that the vast majority of clinical decision support tools that try to, help doctors, like they're just not very good because they don't meaningfully engage with like the measurement problems that are all over the place in actual medicine. And so they're using ICD codes and they're like using these variables that are abstracted from charts. And I don't really blame doctors for just not taking them seriously because they're just not that good. And so for me, it's very hard to disentangle like what is doctors like undeniable resistance to like math and statistics and like that's there for sure. But part of it is also just like these tools are not very good on average. And so I think it's probably both.
All right, great. I see a hand up from Anuj.
Dr. Obermeyer, that was fantastic.
Thanks.
I read ECGs for a living. I read thousands and thousands on GE Muse, which is one of the software platforms. And I correct at least half of the ECGs. Sometimes it's a rhythm issue, sometimes it's overcalling, undercalling. And I've always wondered why GE Muse doesn't have an algorithm that takes into account our corrections and improves its ability to do the automated reads. And I wasn't sure if that's because GE just didn't invest in the efforts or it's too complicated, even though I think 90% of the market goes to GE Muse. So that's question number one. Is there a way to improve that automated reading? The second question I have is Epic and all of these different EMRs have trillions of data points. And I assume that you could probably go back and get EKGs from 10 years from ago and see what happens to that patient. And in ways that a human being like I could never figure out, say, we can find these subtle abnormalities on an ECG and prognostically look 10 years from now and say, this is what happened to these patients before, this is what's going to happen to this patient in 10 years. And human beings will never be able to do that. There are just trillions of data points. We'll never be able to figure that out. Is that something that's feasible, reasonable, doable, and are efforts underway to work on something like that? So those are my two questions. And by the way, that was excellent. I loved it.
Thank you so much. I love your questions. And your first idea is just awesome. Like, I think it's like, I had never thought of that, but this is like a brilliant idea and should be totally doable, as is your second. And I think maybe what I'll do is I'll just answer them by, I think there are two complementary and reinforcing problems that stop those kinds of things from being developed. One is that right now, there's not a clear market for these kinds of tools. And so it's like, who's going to buy that tool? Well, you have to convince, just imagine having the conversation with your CFO and being like, look, we really want to buy, like, you know how that conversation is going to go. And so they're like, part of the problem is that the consumer is not yet sophisticated and, like, to be more charitable, like, no one's demonstrated the value of these tools in the way that, we have, like, you just run the trial. Like but no one's developed the thing and run the trial to show that so that's one. The other side is like the data challenges are just enormous. So like I've now extracted ECGs in 5 or 6 different places. And problem one, most hospitals contract with GE or Philips doesn't actually include the ability to bulk download ECGs. So now you have to actually pay GE or Philips to change your contract and get their help in exporting the ECGs. Two, like the storage formats and like there's just a bunch of frictions and like getting those data online. And then 3, now you've got to link that to the outcome labels from Epic, and then there's all the Epic problems or the Cerner problems or whatever. So this is all very doable. And I'll say that like this company that I helped set up, Dandelion, this is like what we're doing. Like we're extracting all the data, we're linking it, we're cleaning it in order to make that task easier but it is a non-trivial undertaking. And especially when the consumer isn't demanding products. No, that's why I think like no one's doing it. So I think that the market just hasn't evolved, both on the supply side and the demand side, to produce these tools. It's clearly going to, it just hasn't yet.
All right, great. And I do see there's a comment from someone also saying that Epic Cosmos interface is not easily accessible to the average user. And I know that John and some others have tried to use Epic Cosmos and found it maybe not as good as hoped to be.
Yes, good. Understatement of the year. Yeah.
Abdul Hamid.
Yes, thank you for the excellent lecture and very eye-opening. This is a 2-part question, or 3-part actually. For using artificial intelligence in the diagnostic field, your first example for using AI, or call it for known data and known outcomes for the coronary artery for ACS or MI. when you're going through that, the first thing that came to my head, if this is to be applied, this would be basically telling, one way metaphor of this is, when you're first get your bike and you take off the training wheels and you're asking them to take their first ride, it feels very risky to try to apply that, especially in the setting of ACS if we're going to apply that. So the second example you gave for something where you don't have, when you have for a sudden cardiac death in the setting of unknown risk factors, trying to find that and then correlating for a known outcome, I feel that it's probably might be more acceptable, but that's the impression I'm getting, or I came up with through your talk, thinking this through. And then the other part of this is, in the setting of if we classify the data input and outcomes to known unknown, will there be a use of AI in using known data or things that we find into into figuring out unknown outcomes? I don't know if that makes sense, but
yeah, no,
yeah.
all great questions. And I think clearly there's different risk profiles and risk tolerances for all these different things. I think our general approach in terms of applying that ACS algorithm is we're going to try to essentially find a way to, number one, convince the physicians that are participating that this is, providing useful information. So we're going to actually just do case reviews of their cases over the past year where the algorithm has disagreed with them. And then we're just going to show them what happened. And so they're going to be the ones who are going to judge whether this is valuable or not. And then when we give them the predictions, they'll just be able to kind of integrate the predictions into their clinical practice however they see fit based on their personal knowledge of how the algorithm is working. So I think that kind of, and most physicians, I'll say, are they're very worried about an algorithm telling them not to test someone because it's I've decided, so, fine. Most physicians are also kind of blind to the other side of the equation, which is well, forget about that. You just keep testing whoever you want to test. We're not forcing you to do anything, but you might want to know about these very high risk people that are coming through your ED that you're diagnosing with heart failure and sending home on Lasix, who then go on to die. And so I think that the approach is very light touch in the sense that we're not recommending anything. We're just giving you the information after giving you a framework through which to interpret the information however you see fit with respect to your own clinical practice and your case history. So I think that's how I think about the risk, and I think that's true for the ACS thing. It's also true for the sudden cardiac death thing. I think your last comment on measuring new outcomes is super interesting because I think it highlights that as we get more and more data, especially the kinds of data that we're collecting on imaging and waveforms and things like that, I think we'll be able to see a lot more things that we haven't seen before. But I don't think it solves the problem of the human curation and value, what do we think is important? That is a human decision. And I think we can now measure things a lot more, but there's not a lot of substitute for the way that we decide on what's an important question to think about and answer or not.
Thank you very much.
Great. Well, I don't see other hands up. If people want to jump in, certainly they should. I mean, one thing that I guess came up with that last comment too, and I guess must come up with this ECG type studies are, how much do you think about trying to figure out ways to improve transparency? I mean, it seems like it's been a focus of electronic algorithms to make it clear to clinicians what they're doing, but it's hard if you don't know what, if there's no obvious input that's leading to the output. Have you thought about ways to try to make them more understandable or transparent?
Yeah, I think, I've thought about it a lot. I think where I get stuck is that there's no clear, the way that we make sense of anything, whether it's a machine learning tool or something it's very opaque. And so, and this, there's one of those scores, the TIMI score, where one of the elements is you've taken aspirin in the past, whatever, week. That increases your risk. It's like, okay, but aspirin generally decreases the risk. So like, how do people make sense of that? It's like, oh, but it's like, if you're the kind of person who's on aspirin, then it, but like our explanatory models, like what's going on in here just fundamentally like doesn't always make sense, or it doesn't, and it doesn't need to. And I think that's true in medicine. It's true in the rest of our lives too. It's like we think a lot of things that are just confused and superficial and wrong. So I think that, my sense is like, rather than trying to explain which variables are important, let's just like think about what are the errors you're currently making and how do we get insight into like what's going on in your head via this algorithm. And so that's all of the behavioral things that I mentioned of like showing here's the risk score the algorithm assigns. Here's what most humans seem to be doing. Where does the problem seem to creep in? And showing people that way that the algorithm is a useful tool rather than trying to make the argument based on like which X's are important and which ones are. And I think that's both not a statistically solvable problem, and it's also probably not the best marketing tool either.
Great. I mean, a quick follow-up on that too. So I think about this a lot, but do you find there's much of an issue with kind of, I mean, as doctors, often I feel like I'm in the team room and we'll talk about the pathophysiology, like, which receptors are being targeted or afterload or whatever these things are, which are imaginations, of course, of like what could be happening. And does that seem like a barrier, I guess, to the idea of sort of accepting that there's like, data generated scores, but how it fits into this pathophysiological model is really unclear.
No, I think it's a huge opportunity. And I think that's where I'm interested. Like that last project that I mentioned, it's very much about tying those imaginary, pathophysiological concepts into real measures and sort of like models that are quantitative that can generate new hypotheses and let us test them. So I think it's a huge opportunity, and I think that's the right like space to be working in. Really looking forward to meeting anyone who's available when I'm in town.
Yeah, and we're well past the hour, so I'd just like to say thanks again for a really intriguing talk.
Thank you so much. It was really a pleasure.